Right. Hello, everybody. Welcome to the webinar today. I've got a good webinar that's close to my heart. Hormones and endocrinology was kind of my first love, if you will. And that was my first board certification, postdoctorate board certification. I studied endocrinology through the National Institute of Endocrine Research. And it's just been something that I've known, for almost 20 years now is so important. And we do live in an era of unprecedented neuroendocrine disruption. And so it's really important that we support the hormonal systems throughout the lifespan. So today, my objectives are to really help doctors understand endocrinology at a deeper level and at a level that will add more clinical tools to your practice, as well as a deeper understanding of the nuances of endocrinology. So I really, I want to outline the proper uses and alternatives of hormone replacement therapy. The impetus in many ways for this webinar is that I've seen this growing trend of patients coming to me after being on hormone replacement therapy for months, if not years. It might help some, but in many cases, it doesn't help that much. And it does come at a great risk. And in many cases, they're even worse off had they not taken the hormone replacement therapy. So I'm seeing this trend where doctors and medical professionals are quick to just go to hormone replacement therapy. We'll run some tests and we'll see low testosterone or low thyroid or low estrogen, and that's enough evidence to go ahead and do hormone replacement. And it's not enough evidence because the essence of functional medicine is to ask why first. So why is somebody deficient in hormones? Why is their HPTA-G axis not really working? And so we'll go through the principles today of restorative and functional endocrinology and give you a much broader view of hormones and how to support hormones. We'll talk about proper testing and treatment of hormonal imbalances using restorative and functional endocrinology. And also, I want to give you some solid clinical therapeutic interventions in this 50 minutes that we have together. So I always like to say this to my students, as Lyland said in the beginning. I have a nutritional pathology certification course, and it's 6 modules, and 2 of those out of the 6 are dedicated to endocrinology because it is such an important topic. And I often say this to my students: good doctors know what to do, but great doctors know why. So in this time that we have together, my goal is not to just tell you what to do. My goal is to give you the tools to think more about the why and to investigate more the why of hormonal imbalances. So this is what we see on a daily basis, right? Has science found the fountain of youth and hormone replacement therapy? We see these not just in sort of South Florida and Miami Beach, but everywhere, and even pharmacies and compounding pharmacies are promoting this hormone replacement therapy. You can be young forever, improve endurance and sex drive, increase muscle energy and muscle strength, increase bone density. All of these are true, but is this the only way, right? Is there a better way? And more importantly, why is this the only option that patients ever really get when they go to a traditional medical professional? Even if we do hormone therapy, we could do restorative and functional endocrinology along with it. So we all know that there are dangers of HRT. It's been well documented. This is a good study, the controversial history of hormone replacement therapy. It's not all bad. It's not the Women's Health Initiative in the early 2000s, of course, sounded the first major alarm that, hey, hormones, can cause some damage. So in doing hormones, as we've learned from the Women's Health Initiative to do it much better since then in 20 years, but it still carries with it some risks. cardiovascular disease, breast cancer, ovarian cancer, hormone dependency, even depression, and osteoporosis if you do too much, too long, or not enough. And we'll actually talk about osteoporosis today because what I find is a lot of women are told to be on HRT because of osteoporosis. And that is, while that may be somewhat effective, it's actually barking up the wrong tree. It's not even addressing the real causes of osteoporosis. There are known benefits, as we know, too. It's reduced risk of cardiovascular disease if given pre or early post-menopause. Reduced risk of dementia, again, if you give it within 2 to 3 years, peri and post-menopause. Improved osteoporosis for sure, but it's not the only way to achieve that. In hysterectomies, it's certainly needed for improved quality of life, menopausal symptoms, sexual dissatisfaction and dysfunction. All of that, there's no doubt that hormones and hormone replacement can help those. But again, as the theme will be for today, is there a better way? And why are we seeing so many endocrine problems across the lifespan, and not just in menopause or andropause? So we all know the dangers of compounded bioidentical hormone replacement therapy. Now, this particular study was written by the pharmaceutical company, but it has some good points and not so good points. Transdermal estrogen with micronized progesterone is the preferred route, but I'll talk about it, not always. Taking HRT increases the risk of breast cancer, similar, no matter whether it's compounded or regular or prescription. It's similar in this meta-analysis to being overweight or drinking 2 glasses of alcohol every night. Now, in this study, they kind of said, oh, well, that's not a very big risk. That's a huge risk. No one wants to, we know that there's an increased risk in being overweight and drinking alcohol every day. And so, and by the way, drinking alcohol every day is one of the risk factors for developing hormone problems. So we'll talk about that as well. It does treat depression better than antidepressants in some cases for postmenopausal women. But again, is it really treating the cause, which we'll talk about? And body identical or bioidentical compounded hormones are not as regulated. That is a good point, which is why it's important to find a quality compounding pharmacist. This is a great study for the National Reviews, Nature Reviews in Endocrinology, hormone replacement therapy, current thinking. Subsequent reanalysis of data from the Women's Health Initiative with age stratification, newer randomized and observational data actually show that HRT can significantly decrease the incidence of menopause and osteoporotic fractures. It can improve quality of life. And again, in younger, healthier women, the risk balance is positive for using HRT. However, is this the only way? Is this really in alignment with functional medicine principles, which is treating the root causes? Giving somebody an end-stage hormone is basically like firing your own endocrine glands, saying you're not doing a good job, you're fired. We're just going to get it from a bottle or a patch. And is that really the way we want to approach that? And my my practice in 20 years has proven that no, there is a better way. So if you're going to prescribe estrogens, I'm going to go through just a couple of clinical pearls. Run labs first, always. Determine if it is safe and appropriate. The benefits of compounded. You can customize the ratio of estrogen, estradiol, estrone. You can have less ingredients. Creams do seem to be the easiest to tolerate. You can use vaginally, which does actually get into systemic circulation. I actually had a nurse practitioner tell one of my patients, oh, you can take this and it's just for vaginal tissue. Don't worry about it. It's not going to get into systemic circulation. I'm sorry. Is is that separate from the rest of the body? It is attached to the entire cardiovascular and lymphatic system. It does get absorbed just like if you were to put it on your wrist or anywhere else. So start small and test is a good principle. And timing, all steroid hormones have their peak in the morning and then slowly decline to the nighttime nadir. So I'm all about restoring proper circadian rhythm. And so I tend to do it more in the morning and not at night. But we'll get to some of the hot flashes and that kind of stuff. Dosing, here's some of my dosages. For those of you who want a copy of these notes, you can email me. And of course, I go much more in depth in my classes, in my nutritional pathology class. 0.03125 milligrams patch every other day of estrogen, 1 to 2.5 milligrams of Biest or Triest if you're using a patch. 1 milligram oral. If you're going to do progesterone, I prefer topical. We'll talk about that, 5 to 20 milligrams. I often use pregnenolone with progesterone because it allows for less use, and it's good for titrating down off of progesterone. Doctors Data just had a really good article that came out today about postpartum depression and new drugs. Basically, it's allopregnenolone to use for postpartum depression. And you can raise levels of allopregnanolone with pregnenolone and not progesterone, and it tends to be safer. And I use pregnenolone in fertility and preconception planning as well. And in my experience, most women do not need testosterone, even if they're testing really low in testosterone postmenopausally or pre. There's better ways to do it, which things like DHEA and restorative endocrinology is usually enough. So we'll get started with restorative endocrinology. There is a better way. It starts with treating the entire endocrine system and the whole body. Only when one sees the entirety of the cell and the systems and the organs and how they're connected can new treatment horizons actually open up. And that's what I want to provide today. So it starts with taking a journey with hormones and not just the production of hormones, but what do hormones really do at the body? So we're looking at the integration of the neuro, endo, immune, GI, and detox crosstalk here, all of which needs to be addressed if you're going to address hormones in any way, shape, or form, whether glandulars, nutraceuticals, or bioidenticals. Hormones truly are the harmony and communication systems of the body. That's actually why I called my clinic, named my clinic the Harmony Healing Center, because of the understanding of how important hormones are, and that they truly are essential for harmony in the body. But functional medicine does not seek to simply replace hormones, right? Rather, we want to repair, we want to rejuvenate, we want to understand why an endocrine system is not functioning optimally. And this is known as restorative medicine or restorative endocrinology. The first treatment to employ, and perhaps the most important, is always lifestyle medicine, right? This entails educating the patient on diet, exercise, stress reduction, and we'll talk about specifically treating the immune system and endocrine system with that. It's often beneficial to use bioidenticals in the replacement model, but it's usually only if we are doing our job, if patients are educated properly, it's usually only needed for short term. And when it comes to replacement, always err on the side of less is more, because it's harder to get someone off of it if they've been taking too much or too long than it is to titrate up. So first of all, why are there so many endocrine problems? Why do we see so much infertility and preconception issues? Why are males and females born with more ambiguous genitalia? One of my favorite books is Countdown by Shauna Swan, talking about the decrease in sperm counts, the decrease of the anogenital distance in offspring in the last 50 years. And that's because of exposure to xenoestrogens. So all of our endocrine disruptors that we have been exposed to, most of us now living have been exposed to endocrine disruptors since the womb. So we have now, our entire systems have been affected by environmental endocrine disruptors. Being overweight, as we talked about, inflammation, the effect on the microbiome, leaky gut. Leaky gut and the microbiome is one of the single greatest influences on the endocrine system. So why wouldn't we address it and treat it if we're treating the endocrine system, right? Our sedentary lifestyle, oxidation, inflammation, damaging the receptors, nutritional deficiencies like methylation, the mitochondria can't function. Where are steroid hormones produced? In the endoplasmic reticulum, which needs the mitochondria. lack of sleep, lack of belonging, quality relationships, and stress. All of these are the factors that contribute to one being deficient in hormones or imbalanced in hormones or resistant to hormones. So let's take a journey of a hormone, because when we take a journey of a hormone, when we put ourselves in the boat of a hormone, then we can understand all of the factors that affect how the hormone is produced, how the hormone is affects the body and the cell, and how it's detoxed and eliminated. So we have at least 10 points of therapeutic intervention when we talk about endocrinology. Now, everyone knows about production and secretion. When you replace a hormone, that is essentially all you're treating, is one out of the 10 points of treatment. So this is the neuroendocrine regulation. This is the HPA axis, HPA-TG axis. And it's measuring how the endocrine gland is functioning. Where are hormones made, though? Again, in the endoplasmic reticulum. So why are gonadal tissue and adrenal tissues not functioning properly? It really does come down to the mitochondria in many ways. And most people that I have come across who don't understand functional medicine but are practicing bioidentical hormones have no clue as to what's really affecting hormone production. So, and then the gut microbiome, which we'll talk about, and treating and addressing all of these is so imperative. We have transportation of the hormone, right? Sex hormone binding globulin, thyroid binding globulin, albumin. All of these things need to be addressed. So if you have too much sex hormone binding globulin because of being estrogen dominant, or you don't have enough because of being insulin resistant, those kinds of things need to be balanced because it's affecting the free amount of hormones that one has. We're also looking at free receptor and receptor. So enzymes such as 5-deiodinase, right? So T4, the receptor for T4 is T3, and so it needs enzymes to be working properly. And that enzyme is nutritionally dependent, right? It needs vitamin D, it needs selenium, it needs cobalt, it needs molybdenum. 5-alpha reductase is another one for testosterone to DHT. All of those enzymes need to be functioning properly in order for hormones to work. The receptor itself needs to be working properly and sensitive, as well as being able to transmit the phosphorylation signal inside the cell. So we have cell surface and we have nuclear receptors. Nutritional deficiencies, oxidation, inflammation is the cause of most of these receptors not working properly. So no matter how much hormones you give, the receptors are actually going to be more dysfunctional. So when you give more hormones to a receptor that is not functioning properly, it actually downregulates itself to protect itself and to protect the cell. So this is what's happening in so many people taking, oh my gosh, 200 milligrams, 400 milligrams of progesterone, 10 milligrams of estrogen. I mean, I've seen it all, and I'm sure you have too. We have to make sure that the post receptor mechanisms and the translation of the hormonal signal is intact. Phosphorylation enzymes, the cytosol, even the gene, because most hormones, right, the ultimate end goal is to affect genes and gene promotion and gene protection. So proper methylation needs to happen. So that gene activation, transcription, and production of the hormone effect needs to happen, and that is making sure that our glutathione status is proper, our oxidation and inflammation is down. We'll talk about how NF-kappa B completely interferes with almost all of our hormone signals. So it's really, really important that be addressed. Self-regulation, such as counterbalancing effects, signal modification, stop genes, right? The genes have to get the signal and then be able to stop. And again, that is usually enough methylation, or is somebody methylating properly, that kind of thing. Also for detoxification, biotransformation, and elimination. So we have local degradation of hormones and byproducts, and then we have hepatic phase 1 and phase 2, and then the elimination phase, which is biliary, GI, urinary. All of that needs to be addressed. So each one of these points, and there's more, this is kind of simplified, believe it or not, but each one of these points has therapeutic interventions. We won't be able to talk about all of them today, but we will talk about most of them and give you clinical tools. Again, my purpose today is to stimulate your knowledge, to stimulate your appetite, to open the vision of endocrinology so that you can get better education, you can go out and be more supportive for your patients, and you can do that with my classes or other hormone classes, that endocrine classes that teach functional endocrinology. So we'll talk a little bit about selective receptor modulation, how to support receptors. Much attention is given to receptors. So even if you do hormone replacement therapy, you want to support the receptors. Otherwise, those receptors are going to downregulate. And so understanding things like curcumin, resveratrol, genistein can have significant modulatory effects. Being insulin resistant actually decreases progesterone receptor sensitivity by half. So just addressing insulin and insulin sensitivity and inflammation will address receptors. What is the greatest single effect, negative effect on receptors? It is oxidation. It is inflammation. And where does that oxidation and inflammation come from? It comes from, for the most part, leaky gut and the microbiome and this microbiota. The cellular environment itself is perhaps the most important receptor modulator. So if you've got NF-kappa B and IGF and tumor necrosis factor alpha, all of these things are often going to antagonize, sometimes they agonize proliferative effects of hormones. So it is affecting hormones. And this is what I think a lot of people forget. We all learned this in school. It was board questions and things. But as concentration of hormones increase, cells will respond by decreasing receptors. So if you have normal hormone level and normal receptor density, you're going to have normal receptors and normal receptor function. If you have elevated hormone levels, then you're going to get reduced receptor sensitivity, which is why it is very difficult sometimes to take someone off the hormones, because now you're reducing the hormones and their cells are more resistant to the hormone. So you can put them in a very deficient state. So it needs to be done slowly, and it needs to be done along with restorative endocrinology principles, treating the entire body. So let's see. So laboratory testing for restorative endocrinology, we test free and bound levels. We also want to look at downstream effects to make sure that there really is an issue with that hormone. So as an example, hemoglobin A1C is more important than just testing insulin, right? Because that's looking at blood sugar spikes and your glycosylation. Serum electrolytes is often very important in adrenal dysfunction, because aldosterone levels will be affected if there is adrenal dysfunction in most cases. Cholesterol, MCV, those are often elevated in hypothyroidism. So you want to look at the downstream effects. And I go into all of this in my nutritional pathology courses. How to interpret blood chemistry is still one of the most misunderstood tools that the practitioner has. So we look at blood, we look at saliva, we look at urine, like the HUMAP testing for antibodies associated with hormonal disorders, the testing for autoimmune, genetic SNPs, amino acids. These are all important in addressing how, not just number one of the restorative endocrinology list of production and secretion, but how are those hormones actually functioning in the body? So this is an example of the HUMAP testing in urine, which is testing not just blood levels of certain hormones, but also how hormones are being detoxified, how they are being biotransformed and eliminated. So we have all of these that are being estrogens, corticosteroids, androgens, progesterone, even oxidation. So you can get a good idea of how well the body is able to deal with oxidation. And if the body has high 8-hydroxy 2-deoxyguanosine, then it's a lot of oxidation. So that's this down here, 8-hydroxy 2-deoxyguanosine. In this example here, this person had very high 8-hydroxy 2-deoxyguanosine. Now, this is not the only oxidative stress metabolite by any means, But remember, oxidative stress is stripping electrons from the cell surface and the receptors and the hormones themselves. So testing hormone metabolites is even more important when you are doing hormone replacement therapy because biotransformation and elimination becomes even more important than in normal circumstances because you are driving more hormones into the body in not necessarily a normal way. So establishing the validity of saliva versus blood and serum. I continue to see that in most cases, saliva tends to reflect better tissue exposure and tissue levels than does blood. And it makes sense if you understand um, what blood is really measuring and what saliva is measuring. Blood levels are testing short-term production, right? When a hormone produces, testosterone or estrogen, that goes into the bloodstream. It does not stay in the bloodstream very long. Where does it go? It either gets eliminated or it gets deposited in the interstitial tissue and then gets absorbed into the cells. And it's saliva testing that really measures that interstitial tissue milieu. Where do the hormones go and where do they hang out? They can hang out for weeks in the lymph system and interstitial tissue, whereas it's only hours in the blood. So it's much akin to the analogy I often use is if we're testing for heavy metals, right? Blood, is usually very short-term exposure to a heavy metal because it's either getting deposited into tissues or it's getting excreted. So, if you got exposed to a bunch of hormones or a heavy metal, a few days ago, that's not necessarily going to show up in the blood. Whereas if you do a urine test, if you do a challenge test, which is pulling those heavy metals out of the interstitial tissue and out of the organs, then you get a better idea of what's really in the tissues. Okay, so that's why saliva tends to be good. And in the case study I'll do at the end here, I'll show you why that is the case. So just good studies demonstrating the validity of saliva as not just in research but in clinical. So functional approach to endocrinology. The treatment principles are treat the patient, not just the labs. We want to run the labs, but we also want to be aware of how the patient is feeling. So I had a patient not too long ago that came to me, and I think she was only 52 or 53, and she was put on estrogen and progesterone simply because she had osteoporosis and no other symptoms really, maybe a couple little hot flashes, which by the way, is just because, and hot flashes, certainly if it's affecting quality of life, it should be treated. But just because you say hot flash doesn't automatically mean, oh, your hormones are out of balance. It is normal and natural to have symptoms of lowered estrogens and progesterone in such a short time. So this person was put on, large amounts of estrogen and progesterone, and it actually made her symptoms worse. The bone density looked a little bit better, but her symptoms were worse. So treat the patient, not just the labs. Lifestyle factors first. Treat multiple systems at once. Your gut, your microbiome, your mitochondria, the receptors, the endocrine system. Experience will guide you in determining the primary factors with each patient. Treatment is always aimed first at restoration and replacement only if absolutely necessary for a short period of time. The most non-invasive treatments in order typically go botanicals, nutraceuticals, glandulars, and then combinations of the three, plus then your compounding or end-stage hormones. So this is a good study highlighting how lifestyle factors are the primary causative factors in much of the menopausal symptoms. So vasomotor symptoms and insulin resistance, a study of women's health across the nation. And they found that compared to no hot flashes were associated with higher insulin resistance. And so just treating insulin resistance does the same thing as bioidentical hormones or hormones in a safer way and more healthy way, because if you treat insulin resistance, right, they have greater bone density, they're exercising, they have greater muscle mass, those kinds of things. They lose weight. So that becomes a much better treatment than just giving someone estrogen. An exploratory study on perceived relationships of alcohol, caffeine, physical activity on hot flashes in menopausal women. And I'm just talking about menopausal women. As I said, alcohol in and of itself is one of the greatest inflammatory things you can do to your body and to your endocrine system. But there are positive correlation of the number, severity, and duration of hot flashes with stress, caffeine, sugar. Like I said, insulin resistance decreases progesterone and progesterone sensitivity by half. Alcohol consumption and BMI, a negative correlation with physical activity and vegetable intake, and also the microbiome and affecting the microbiome in other studies. So we have these things that I think a lot of practitioners don't want to deal with. It's easier to prescribe, but hopefully everyone listening today, if you are practicing in that way, will start to understand that there is a bigger picture. There's a better way of doing it. And in my experience, I almost rarely have to do hormone replacement therapy. It's great to have when you need it, but if you use these principles, you help your patient become so healthy, so much healthier that their endocrine system starts functioning normally and optimally. So I want to talk about osteoporosis for a minute, because this is often used as solely as a reason to prescribe bioidentical hormones or hormones, end stage hormones. So osteoporosis is really a lifestyle disease. It doesn't happen in menopause. It doesn't happen because hormones are low. Hormones do have an effect, but not the largest by any means effect on bone health and bone density. So it's an inflammatory. If you truly have osteoporosis disease, and remember, DEXA scans only look at bone mineralization. It does not look at the health of the bone. 80% of bone is cartilage. 80% of bone is healthy, living tissue, not just calcium and minerals and strontium and boron and those things which are needed. Which, by the way, estrogen doesn't really help with that. You need those minerals. So what does cause the osteoporosis is really inflammation. So doing things like exercise and whole body vibration, weight bearing, healing the gut, doing an anti-inflammatory diet, and decreasing the inflammatory milieu and the inflammatory cytokines. So in this study, osteoporosis and inflammation, human and animal experiences have implicated pro-inflammatory cytokines as primary mediators of the accelerated bone loss at menopause. So it's going into menopause preloaded with inflammation, and that's usually a lifetime thing, right? You don't just become inflamed in menopause. And it's the same kind of thing that happens with rheumatoid arthritis, periodontitis, multiple myeloma. Um, in this study, temporal differential effects of pro-inflammatory cytokines and osteoclastogenesis. Again, NF-kappa B and the ligand rankle. So it's really treating the rankle, which is the receptor for the inflammatory cytokines that trigger osteoclast. And here we have so many different, I'm just giving you a smattering, a little taste of things that we do in my practice and in functional medicine to help with bone density. So here, Panax ginseng was actually just as effective as hormone replacement therapy. Other anti-inflammatory nutrients such as curcumin, resveratrol, folate, B12, even probiotics has been shown to decrease osteoporosis and improve bone health. DHEA, green tea extract, and I've got just a few studies here. So this study, curcumin protects osteoblasts from oxidative stress-induced dysfunction. Again, it's pretty much well known and understood and accepted that it's an inflammatory issue. Who's talking about that? Certainly not the average, hormone replacement therapy clinic. So we can see that it's NRF2 that needs to get activated. It's glutathione. It is things like N-acetylcysteine, green tea. It's reducing these perioxide nitrates here and hydrogen peroxide metabolites. association between tea consumption and osteoporosis. Positive correlation between right here, 8-hydroxy 2-deoxyguanosine, which we saw in the HuMap test, and is lowered when you increase your intake of green tea and green tea polyphenols, and not just green tea polyphenols, but all polyphenols. My favorite, as we'll look at later, is grapeseed extract. DHEA and bone health is well known. So just doing a little DHEA, 5 milligrams. Most of these studies show 5 milligrams has the same effect as estrogen and progesterone combinations in much safer ways. This is a position statement of the expert panel of the Polish Menopause and Andropause Society that supplementation of DHEA is more effective or as effective and safer. And so in this study, 1 year therapy with 10 milligrams a day DHEA alone or in combination with HRT in postmenopausal women, what are the effects? And it found that DHEA produced a significant rise in androgen levels, whereas HRT did not. Moreover, DHEA alone induced a significantly lower increase in estrogens than obviously HRT, but enough that it had similar effects on the receptors, similar effects on the bone density, similar effects on the hormone milieu. So a randomized placebo-controlled double-blind trial of pregnenolone for bipolar depression. I throw this in here because I am a big fan of pregnenolone when needed. Usually 25 to 50 milligrams a day. Now here in this study, they titrated up to 500 milligrams a day. But most of the study group with severe bipolar depression improved. And this is kind of what I was talking about with the study with postpartum depression, that pregnenolone alone, because it affects the GABA receptors and other receptors, it can be very helpful for postpartum depression, for bipolar depression, for a lot of cognitive issues as well. So dementia and those kinds of things. And I want to bring in now the gut microbiome and how important the gut microbiome is to the endocrine system. So research suggests that menopause is associated with lower gut microbiome diversity and a shift toward greater similarity to the male gut microbiome and more inflammation. And so treating the gut microbiome or the estrobolome, as it's sometimes known, can be a very, very effective tool. And the doctor's data has some webinars that have addressed that, as well as I address that in my courses. So we can see here that, down here, the gut microbiome diversity in women and men as women go into menopause, the gut microbiome, the estrobolome goes down and the diversity goes down, and the translocation, so leaky gut, tends to increase in menopause and perimenopause. So treating leaky gut, and I don't have time to give you all the studies because I've got thousands, but there's some really good studies on treating leaky gut and estrogen and menopause. So, and it's something that we addressed at the Lens conference earlier this year, how important the microbiome is to hormones. Specifically, I focused on fertility and preconception. So let's talk about a case study here. This is Mike, 50-year-old male, and it looks like we've got about 15 minutes, so we're doing good. 50-year-old male. He's overweight. His BMI is 32. His vitals were within normal limits. His chief complaints were fatigue. His liver enzymes were elevated, and he had low T. He worked with an MD for 6 months, giving him testosterone and giving him glutathione because he thought, let's give him glutathione. This is a medical doctor who we'll say, have the best training in functional medicine. You go to a weekend seminar and you hear about the benefits of glutathione and you think you've reached the holy grail. But it's the ability to apply the right therapies to the right patient at the right time. That's what makes you a great doctor. Again, Good doctors know what to do. He wasn't even really a good doctor, but great doctors know why, and that allows you to apply the right therapy to the right patient for the right reason at the right time. He was never even really given a diagnosis. He was only treated with testosterone shots 2 to 3 times a week and glutathione. Always ask why? Why is this happening? Why is this happening? Why does he have low T? Why does he have ED? Why does ED is not just a hormonal deficiency. There's so many causes of ED. It's psychological. It is cardiovascular. It is inflammatory in nature almost in every case. So he didn't feel much better. So he came to my office. So I would ask you right now to just take a second to think about this. You've probably seen cases like this. If not, you're going to more and more if you're going to treat hormones because this is happening still even worse. It got worse through COVID and now post-COVID because while long COVID absolutely has a correlation with low hormones, hormone replacement therapy is not the correct treatment. Low hormones are a side effect. It's a consequence of long COVID, not the cause of long COVID. Although going into having COVID with low hormones definitely can increase your risk for long COVID. But treating it is with hormones and hormones only, the entire pathophysiology of long COVID, which is mitochondrial dysfunction and inflammation and organ and brain HPA TG axis imbalances and working with the autonomic nervous system. That's another lecture that I give, and I'll give you some options of coming to my lectures, listening to my lectures at the end of this one. So, what labs would you run? You know, would you run blood hormones? Would you run saliva hormones? Would you run a micronutrient test? Would you run an organic acids test? And why? A stool test. I'm only asking you to think about what are the options and what are the clinical rationale for doing so. So we ran his blood work. Every one of my patients get this, what I call the Lundell Deluxe panel through LabCorp. And if you want those codes for LabCorp, you can email my office. I'll give you my email at the end of the lecture. But these are all-in-one codes that can save you and your patient a lot of money. You can see his glucose and hemoglobin A1C is elevated. Uric acid is elevated, and that wasn't being treated at all. What are some of the causes of elevated uric acid? Well, it can be dehydration. It can be not enough folate, not enough B12, not enough molybdenum, not enough selenium, not enough vitamin D. What was that book by Perlmutter a few years ago? Drop Acid. How important it is to keep uric acid levels down. It's likely for him, an inflammatory consequence. His tissues are breaking down and turning over at a high rate. So it's an inflammatory issue. And we come down, his red blood cell magnesium is a little bit low. So I have a blood chemistry manual that you can get from my website, and I go into the functional ranges here. So for instance, sodium serum at 137, that is almost a 90% correlation with low adrenal function with HPA dysfunction, HPA axis dysfunction. And I've got the data to prove it, and there's studies out there. Why? Because sodium serum reflects as a good surrogate marker for aldosterone production in mineralocorticoids, which almost always gets affected in long-term adrenal dysfunction. So all of this we go over in my classes. And here we see the AST and ALT and GGT is very elevated. His vitamin D is low. His triglycerides are elevated. His CRP is elevated. His homocysteine is elevated, none of which were being treated by a shot in the butt with testosterone, right? In fact, it was probably making it worse. So what was his real issue? Make the correct diagnosis first. What is his issue? Well, to a quick diagnosis is non-alcoholic fatty liver, right? That's a pretty obvious one. The CRP, the triglycerides, the AST, the ALT, that certainly needs to be addressed. And my goodness, if you're going to give someone hormones with fatty liver, well, you might as well just tell them they're going to get cancer in a few years because their liver is not able to metabolize it correctly, properly, safely. And so that is not something that you want to do. Again, you can do testosterone if you want to, but this should, the principle of restorative endocrinology is this should be addressed at the same time, at least. So we continue. His thyroid was okay. His sex hormone binding globulin was low, likely because of the testosterone and likely because of the insulin resistance, right? He was pre-diabetic. He was insulin resistant, which causes the fatty liver. He was overweight, inflamed. Look at his insulin level. His insulin levels were elevated. But here's the kicker. Here's something that I really want everyone to pay attention to. He had just had a shot about a week ago when he came to my office and got this test. About a week before, maybe 10 days at the most. He couldn't quite remember, but it wasn't very long. Look at his free testosterone. It was low, okay? And total testosterone was low as well. And he had just gotten a shot. So where did all those hormones go? It certainly wasn't making him feel any better. So where did all those hormones go? By the way, this is what happens when you give shots, or even when you do troches, or in some instances, it's also doing it orally. But certainly with intramuscular, this is what you're getting. You're getting these massive spikes every time the hormones come up here at the high blue and over the blue, over the upper limit of normal range. You are getting testosterone resistance. You are getting production of DHT. You are getting more problems and more symptoms of low testosterone, which creates a dependency, which I know is the pharmaceutical model. Let's create a dependency on these medications, even hormones, but that's not the functional medicine model, right? And then it goes down very quickly. And again, where do those hormones go? Some of them are used by the body, and some of them are actually stored in the body. Okay. So when we run a saliva test, we ran a saliva test for him. Sure enough, all of his hormones, his cortisol was low. This correlates with the sodium serum. So, and then his nighttime cortisol is high. So he's not getting clock gene repair. He's not getting, autophagy. He's not sleeping well. This is the reverse curve. This is associated with autonomic nervous system dysfunction and stress, leaky gut, all kinds of things when you have elevated nighttime cortisol, which we treat quite effectively with mindfulness-based therapies, with a little melatonin if needed, with phosphatidylserine, with kava. Kava is one of my favorite. Kava is also a GABA A agonist, and it's very effective, very safe. And we have 30 years of research proving that it's very, very safe. But here, again, I want to bring everyone's attention to the elevated testosterone. This was done the day after he had the hormone in the blood, the low testosterone in the blood taken. And so why would his testosterone be elevated in the saliva, right? And not in the blood? It's proving time and time again what I am hoping everyone gets out of today is that these hormones go into the tissues and they stay there for days, weeks, months, sometimes even years. And they are still having an effect on the body. And so people are being overdosed, even if you're doing hormone therapy. So the take home is that if you are doing any kind of transdermal or sublingual, then you need to test the saliva, which is the where the hormones are going. And even if you're doing oral, but oral blood tests are a little bit better if you're doing just oral than if you were just doing transdermal. But in general, saliva is going to be the best measurement of what the cells are getting exposed to. So we did a stool test as well because we know that the microbiome is directly linked to non-alcoholic fatty liver disease. And sure enough, he had Klebsiella, he had Pseudomonas. This is your classic dysbiosis, right? Your beta streps, which is pretty inflammatory. And the Klebsiella, these are gram-negative bacteria that secrete these chemicals of inflammation, the cytokines that go into the liver, and together with insulin causes a lot of problems. And so that needs to be treated. His secretory IgA was elevated because his body was alerted to the fact that, yes, there are microbes here that shouldn't be here. And his short chain fatty acids were very low. Short chain fatty acids, by the way, are selective receptor modulators. Okay, they help sensitize estrogen, testosterone, cortisol receptors, both in the body and in the brain. So we use short chain fatty acids, and of course, we want to produce and colonize good bacteria that produce short chain fatty acids. So make the correct diagnosis first: fatty liver, prediabetes, pancreatic oxidation, pituitary dysfunction, systemic inflammation, dysbiosis. So why did he have low T in the first place? Right? Why? Why? We asked why. Does he need testosterone shots? Clearly he was low. He had the labs to prove it, and he had the symptoms to prove it. Uh, why? If we ask why, it's due to his insulin resistance, cutting off blood flow to the gonads, his sedentary lifestyle, the inflammation that was damaging his brain and the HPA TG axis, and it was the autonomic nervous system dysfunction, all the leaky gut, all of that is what needs to be treated. So we put him on an anti-inflammatory diet. You can get that from my website and my courses as well. We started him on exercise and resistance. We did mindfulness training. And here's the supplementation that we did. We did N-acetylcysteine, we did alpha-lipoic acid, 1 gram a day, grapeseed extract, cordyceps, quercetin, milk thistle, diindolylmethane, so his body can eliminate the estrogens and testosterone in his body properly. We did 6 grams of fish oils, put him on a multi, a mineral. We did methylation support, glutamine to heal the leaky gut. He was also low in SAMe, and without SAMe, you cannot produce hormones. So if you have elevated homocysteine and low SAMe, Dr. Data has a methylation plasma profile to test SAMe levels. If it's low, then the genes cannot produce the hormones in the first place and neurotransmitters, which is likely why he was low in melatonin as well. CoQ10 for the endoplasmic reticulum and the mitochondria, chromium because he was deficient in that. We did a micronutrient test. We did some other tests as well. We did the right probiotics. We did DHEA, only 25 milligrams twice a day. We waited to start testosterone for 2 months since he's still detoxing his testosterone injections. And then we wanted to see if he even needed it at that point, if we could get his Leydig cells and Sertoli cells back online in the testes. And we did a testosterone stimulation formula: tribulus, fenugreek, horny goatweed, maca, all very effective. Vitamin D, because he was deficient in that as well. So for adult males with low testosterone, if you do want to do dosing, short term, because he had such a bad quality of life. So if you want to do it, in the beginning while you're treating these other things, you can start with a 10 milligram cream, but caution against trough and injections, troches. Test after 4 to 6 weeks, or if symptoms worsen. If using sublingual, 15 milligrams. But maybe just even every other day. And you could only need this for a couple of months while you are doing restorative endocrinology, because restorative endocrinology takes time. So grapeseed extract is also something that we did for him. And that was in his nutraceutical list. Grapeseed is one of my favorite because it lowers insulin resistance. Cordyceps is also really good at increasing gonadal function. Grapeseed is great for ED and gonadal function. It treats hyperglycemia. I mean, these are some great studies here. This is one of my favorite studies. And decreases oxidative stress throughout the body, increases cognitive and memory dysfunctions. Similar, if not better, than doing hormone replacement therapy for menopausal women, which certainly does lower the risk for Alzheimer's and dementia. But there's another way, is what my point is today. This is just some of the studies that they included in the review study that improves lipid profiles, positive effect on the pancreas, diabetic neuropathy, alleviating urethral dysfunction, albuminuria, vascular disease, cholesterol levels, peripheral neuropathy. Why are we not using this? I mean, I am, and I hope a lot of you are. But after today, I hope you're using this even more in your practice. Just make sure you get a good quality one that has high polyphenol content, because the one knock on the supplement industry is that there's a lot of bad players out there. It is regulated, but the FDA doesn't have enough manpower to actually, or woman power, to actually, enforce the laws and to go visit these things. So use reputable companies, use standardized grapeseed extract. Neuroprotective effect against dementia, oxidative stress against the liver, protects the gastrointestinal tract, and it has pronounced antimicrobial effects as well. And people think only grape seed extract does, but also grapefruit seed extract does, but it's actually grape seed extract as well. Another important point to reiterate is steroidogenesis happens in the mitochondria and endoplasmic reticulum. So alpha lipoic acid is one of my favorite for supporting hormone production as well as endocrine disruption, right? It's treating the causes of endocrine imbalances, of these xenoestrogens, declining sperm counts. Countdown, again, is one of my favorite books if you haven't read it yet. How Our Modern World is Threatening Sperm Counts, altering male and female reproductive development, and truly imperiling the future of our civilization. And that's not an overstatement. If you do the research like I do and have been for 15 years, this is why I get up every morning, and I'm excited to give this information because it's real, it's necessary, it's needed, and there are things that we can do about it. So we talked about these things already for the case study. I gave a talk last year on low testosterone with doctors' data. It's also, again, why I spend 2 entire modules, almost 25 hours, so 2 weekends on endocrinology. And so a third of my nutritional pathology course is on hormones because it's so important. Some tea renewing herbs that we use. I have all the studies for these, so well researched and well tolerated. So Mike lost 40 pounds in just 6 months with this treatment program. In the 6 months he did glutathione and testosterone, he got worse, felt worse, and spent a lot of money doing it. More energy than he had than when he was a teenager. He can focus on his business now. He started a new relationship, which he later got married. He struggles with workouts, and he still has a sweet tooth, but he's doing fairly well on the regimen. I always ask two things of my patients: to be patient in allowing these things to work, and also to be consistent. We don't have to be perfect. So thank God, because none of us would be healthy if perfection was a requirement for health. We can see his glucose levels drop dramatically in just 6 months. His hemoglobin A1C is almost in normal levels, maybe not optimal, but certainly a lot better, from 6.3 to 5.7 in just 6 months. His sodium serum went up a little bit. His liver enzymes are now normal. The cholesterol and triglycerides are still high, but he was probably 80 to 90 pounds overweight. While you lose weight, your cholesterol, because you're mobilizing those free fatty acids, those are going to be elevated for quite some time until you reach your true set point, which can actually take years. His CRP is down to 0.5, and again, in just 6 months. His homocysteine went up, it did go down because it was at a 9. And he's producing more SAMe. So we ran his saliva test. And again, this is not always the case in just 6 months. Sometimes it takes longer. But his cortisol levels came back and his nighttime cortisol levels went down, which is exactly what we want. Now, his DHEA did go up, and that's okay. That's why we test. So we're able to, move the target. His DHEA levels went up because we did DHEA levels, but so did his testosterone went back to normal levels. His blood testosterone levels also went up to normal levels. And more importantly, all 10, all 9 or 10 of those restorative endocrinology principles, not just production and secretion, were addressed. So all of his hormones were able to function properly throughout the entire body. So that's what restorative endocrinology is, right? That's the power of it. If you treat the person as a whole. So in summary, in conclusion, to just kind of wrap all this up and give you some takeaways, HRT is often needed and it's often not, right? There's other ways. Most cases of hormonal imbalances are environmental and lifestyle and modifiable. Treat inflammation, treat oxidation, treat your mitochondria, alpha lipoic acid, carnitine, CoQ10. Those are standards for mitochondrial function. Endocrine abnormalities are on the rise, and it starts in the womb. So we need to treat the parents for the sake of the children. So we don't have children already behind the curve with hormones and endocrine dysfunction. And support endocrine restoration with diet, with exercise, with what we do, nutrition, lifestyle optimization. It's not the quick fix, but it's the true fix, right? So your anti-inflammatory diet, nutraceuticals like alpha lipoic acid and fish oils, treat the microbiome, use botanicals, your adaptogens, hormone precursors like DHEA, glandulars if you need to, and then hormone replacement with this integrative, restorative endocrinology support as a last resort. So I hope that brought home some important points and you took away some really key clinical pearls of maybe how to do HRT and not to do HRT. But certainly I want you to leave with understanding that there are better ways, more complete ways of treating endocrine imbalances because it is desperately needed. There's no doubt people's hormones are suffering. So if you want to know more about restorative endocrinology, functional endocrinology, I have a certification course, as was mentioned in the beginning. The entire course is almost 100 hours. I went through the IFM, I went through the DAPC program, I went through all of these National Institute of Endocrine Research, and I condensed this into a very practical, easy to follow program. And, we cover blood tests and infections and clinical pearls of, methylation, and we cover autoimmune and immunology, infections and gastroenterology from A to Z. We cover the entire gastroenterology function. Module 4 and 5 are my endocrinology modules. You can purchase each module by themselves if you want to. They are standalone modules, but I do recommend doing the whole thing because all of it has to be done together. And then module 6 is cardiovascular and metabolism, energy regulation, case studies. So if what I'm offering to Doctor's Data, all of the listeners today, $500 off code. So email me, and I will also email you any codes that you want for the LabCorp deluxe panels and things. So email us at hhc@drbrandonlundell.com. You can visit my website and peruse my courses as well. I also offer a functional medicine mentorship program where I take you through the program, and we meet with a small group every other week and then one-on-one for a half hour every month, and we go through the program. I'm starting another one in November, so if you're interested in that, we'll put you on the list. And by the way, I'm excited to announce that Doctor's Data is officially sponsoring my mentorship program. So if you sign up for my mentorship program, you actually get a stool test and a HUMAP test. So I'm very grateful for Doctor's Data in sponsoring that. And that's, what is that? A $500-600 value right there. So we make it as affordable as possible. Believe me, this kind of education, if you go through other programs, you're going to spend 3-4 times as much. So thank you, Doctor's Data, Lylan. I think we have some time for questions, a few minutes.